Good afternoon and welcome to today's presentation, Integrated Pharmacy and Telehealth Deliver Complete Care. Today's executive web briefing is brought to you by Open Minds and sponsored by Genoa Healthcare. This afternoon, we're joined by Summer Malik, Executive Vice President of Genoa Telepsychiatry, and Kevin O'Connell, RPH, Director of Operations of Genoa Healthcare. During our time together, we'll discuss how integrated pharmacy can help maximize your telehealth program, best practices for delivering telehealth services in tandem with on-site pharmacy, and share real-life examples of how on-site pharmacy and telehealth have played out during the COVID-19 crisis. You may notice that all attendees have been muted for today's presentation. We're recording today's event, and muting the phone lines assures the highest quality of sound. However, we do encourage you to submit questions via the question box on the GoToWebinar panel at any time throughout the presentation. At the end of the presentation, we'll hold a brief question and answer session. So without further ado, I will turn the floor over to Summer.
Thank you, David, and thanks to everybody at Open Minds for putting this together and giving us an opportunity to share some of our work at Genoa that we've experienced during COVID and how we view behavioral health coming out of the other side. Let's go to the next slide. What we'll be going over, Kevin and I together today, is the rapid rise of telehealth, what that means for our ability to adapt given a new environment with COVID-19, the role on-site pharmacy can play in thriving on patient outcomes in a telehealth-driven world, and then the future of telehealth. So we'll have time for Q&A at the end. Looking forward to the discussion. Let's hop to the next slide. So the rapid rise of telehealth. Going over to the next slide, one artifact we've had, which should be of little surprise to many of you, is that we were able to deploy a survey to many of our community mental health partners across the country and ask them, well, how have they shifted the type of care that they are delivering today via telehealth? And what we found is that over 90% of the clinics that responded had used telehealth in a more assertive way given COVID and the onset of social distancing. And looking at a more detailed level, we found that 81% of the services being offered by these clinics were now being delivered via telehealth. The graph on the right really shows how folks have used telehealth in a unique way. Psychiatry, of course, deploying telepsychiatry to help members access or patients access services from their home, but also individual therapy and some of the more forward-leaning clinics employing services like group therapy, case management, et cetera, all via telehealth as well. So it's been a interesting observation to note how quickly organizations have pivoted to be able to create continuous care and support patients via telehealth. Certainly, hopeful that this distribution is at least reflective of the audience here, that you all have seen similar shifts in telehealth. So let's hop to the next slide. And sitting at a more administrative level, thinking about, well, what does this shift to telehealth mean for patient care and for outcomes? We've been able to observe within Optum, for example, data showing that no-show rates are dropping when patients are being able to be seen from home. No longer are patients having to figure out how to access transportation, commute, negotiate work schedules or supervision schedules and squeeze an appointment in. But instead, because they're able to access the services from home, we're seeing as much as a 20% drop in no-show rates across our clinics. That means that patients are using the convenience to access care better. There are certainly some wrinkles here because you have an exclusion bias. Patients who aren't being seen via telehealth because we didn't set up appointments because we knew they couldn't access telephonic or video services, they can't not show up to an appointment that was never created. So there is some data bias here, but still, for those who have access to the resources, to see a drop in no-show rates says something about the potential for telehealth to have a continuous impact for patients into the future. Moving forward, what we've found as well is high engagement from both clinicians and patients. The ability to deepen relationships via telehealth that perhaps was only considered possible via in-person services, We're seeing very high patient satisfaction scores with telehealth across the board, 4.8, 4.9 out of 5. And we're seeing a deepening of relationships, providers more committed to the programming, their ability to insert convenience into their workflow and work from home is creating more consistency in patient and provider care as well. And lastly, one thing we've seen is using telehealth has allowed organizations to really build out a team of providers remotely. Whereas traditionally it was thought that the team that surrounds a patient are the folks who are at the clinic, maybe the case management staff, the nurses, the pharmacists, because they're all under one roof. Now that all touch points with the patient are being delivered via telehealth, the range, the breadth of the team supporting the patient has expanded as well. Increased use of primary care, increased insertion of active case management. Services like this that may have been tough to deliver under one roof, now that the roof is a virtual roof, has created broader and perhaps more patient-centric care teams. So let's hop over to the next slide and talk about some of the opportunities in front of us and challenges that yet remain. So as the data showed, continuity of care, creating consistent outcomes for patients has certainly been demonstrated through the increased adoption of telehealth. We've also seen that you're reducing the risk of transmission or exposure, both for your staff and for patients. No need for human-to-human contact, no need for stockpiles of PPE when care is delivered remotely. And then lastly, based on some of the satisfaction data we've seen, we know that some certainly do prefer telehealth over in-person services, and this is demonstrated in the drop in no-show rates. But just because we've taken what we were doing and now done it virtually does not mean the story is complete. In fact, to simply done what we've always done, to do what we've always done via telehealth actually leaves many gaps in providing consistent care. And this is what I think the next chapter in the transition to telehealth will be about, is how do we think about workflow technologies in addition to video technology? How do we exchange information between providers well when they are remote? How do we collect information from patients and get that in front of clinicians, case management staff, nurses, and providers effectively when patients may not be coming in? We need to innovate and develop tools and resources here. Another area that we see as a potential risk is the potential for reduced engagement. Some patients aren't able to connect via video. They may only be able to connect telephonically. They may not be able to preserve a relationship in a video medium that they can in person. We have to keep our close eyes for which cohorts of patients are well suited to be served via telemedicine versus which ones may not be, and then being thoughtful about the application of telehealth accordingly. Lastly, there are some therapeutic benefits to getting out of one's home or residential setting and being out and about in the community. To be able to deliver care in the home perhaps can compound on feelings of isolation, can accelerate the notion that we are in a potentially public health dangerous environment and create additional triggers towards stress and anxiety. So while we don't have answers to these challenges yet, we now have a whole country full of telehealth experimenters and pioneers thinking through some best practices to address these challenges, and confident that we'll have good solutions. And we can talk a little bit more about this later on. But before going too deep down the telehealth path, I'll turn it over to Kevin to talk a little bit about pharmacy as well.
Yeah, thanks, Samer. Let's just check, make sure my microphone's working. Can you hear me, Samer? I had a little technical difficulty there. Wonderful. So great, thanks. Just as clinics have had to adapt to COVID-19, so have pharmacies. We've tried to find a way, how do we deliver the same high-touch, results-oriented care that we've been giving in an increasingly distant, socially distant world? But this is really where integrated pharmacy has shined. We've been able to not miss a beat in being able to provide access to our consumers, solve their access issues, and still being able to connect with them. So Genoa pharmacies, we've had to move very quickly to adapt to COVID-19 situation. maintain access, even when some of our clinics have been forced to close due to safety issues. And if you can go on the next slide here, you'll see how we've, one more please. So we wanted to make sure that we gave consumers the option to still come into the pharmacy, or at least come to the pharmacy, as Summer said, getting them outside into some fresh air. So 69% of our locations are actually offering curbside pickup to consumers to make sure that it is contactless as possible, but still giving them the opportunity to come to their pharmacy should they wish to. You'll see to the right that we've, in the flip side, we've had a 71% increase in mailing. So in order to keep everything as contactless as possible, between the months of February and April, we increased the amount of prescriptions that we've had to send directly to consumers' homes for no touch contact, 71%. Of course, with a little mask icon down there, we've had to increase the health and safety of both our consumers and our employees. So we've had to make sure that we had adequate supply of PPE and sanitation. We have a disinfecting schedule of our pharmacies on a regular basis. And we've even had to install plexiglass in some of our locations to make sure that if there is going to be front-facing patient care, that we do have a barrier to keep both consumers and employees safe. And increased outreach is also one thing I want to focus on. While we make it an effort every day at Genoa Healthcare to engage our consumers and keep them in a close relationship with our pharmacy team, we've done increased check-in calls, following up on consumers on new medications or change in therapy to see how they're doing, or just let them know that the pharmacy is thinking about them. It actually goes a lot further than you think. We do refill reminder calls, calling every consumer to make sure that they are ready for their refill, that they don't have too much or too little, and to make sure that we're relaying that information back to the prescriber of that medication. Some of our teams have actually come up with really creative ways, since we're being the most distant in mailing and not seeing people's faces, we're including little crossword puzzles or games to engage them during COVID-19 and just let them know that we're thinking about them. We can go on to the next slide. So, Genoa Telepsychiatry, our telemedicine platform, now is available to clinics and providers for free of charge during COVID-19. As you can see on the slide there, we've delivered over 3,000 plus hours of care since the onset of COVID-19, something we're very proud of. So the platform is available for both behavioral and primary healthcare needs. And the program setup includes both the tech setup and the training of how to use the platform, the video platform itself, clinical workflow development, how you get converse facing in front of their prescribers and how to best make that work. Ongoing program support. We want to make sure that you have support through the entire duration of using the platform. And we want to make sure that you can increase your demand due to the impact on patients. Some locations will actually even let patients be seen from home using the platform. So that can really be useful in certain situations. Next slide, please. So we've learned how to survive, but how do we thrive? How do we use integrated pharmacy in connection with telehealth as a tool for your clinic to both improve outcomes and strategically place your clinic? Let's move on to the next slide, because I'd like to share a story. I'm proud of this one. It actually comes from one of my pharmacies in Pawtucket, Rhode Island. So one of our regular consumers there had gone to his Suboxone clinic about a week into COVID-19, and he found that it was closed. And there was a note on the door. The note read, told consumers how to engage with the telehealth prescriber and how to set up an appointment, but the consumer actually was illiterate and he had nowhere to turn. So he felt so comfortable with our pharmacy and our pharmacist at the site, Sue, shout out to Sue. The pharmacist connected with the telehealth provider, helped him set up an appointment, and the telehealth provider and the pharmacist actually discussed how they could possibly, in short term, increase his day's supply so that they could shorten his anxiety about having to do increased visits and not being able to get into the clinic. We filled his prescription later that day and he didn't miss a beat. So kudos to my team in Pawtucket there. And we hear stories like that across our 500 plus pharmacies, just pharmacists and technicians working with clinicians to solve access problems, unique problems for each consumer to make sure that they stay on their medication. Next slide, please. So how do we create a seamless consumer care experience? It's really easy right now for things to seem impersonal. We had hoped to be there in person with you all today, and here we are sitting in our offices in our homes talking to you through a webcam. How do we stay connected and close the gap during these socially distant times? So having an integrated pharmacy on site really acts as a critical care bridge between your prescribing team and your care team, and what happens to them once they leave. What happens once you write a prescription to them? You have a debt for patients. Unlike retail pharmacy, they have to operate within the constraints of volume. They have to service everyone pretty much the same way and quickly. Our teams want to work with your organizations to solve your consumers' unique problems and find ways to stay on your clinical goals as well. Our pharmacy team will relay information about the prescriptions that you prescribe. So that includes medication adherence data directly to your clinic as well as the prescriber. Unlike off-site, where you have no idea if that prescription is ever filled, or often if you are informed, it's from claims data that is often too late. It's really a warm handoff if things go off track. I'm a pharmacist myself, and I can tell you that consumers feel very comfortable talking to their pharmacist and pharmacy technicians about what's working and, more importantly, what's not working. And we can relay that information directly back. Pharmacists have a wealth of knowledge about medications, and we really hope that once you have an integrated pharmacy on site that you use that knowledge base. Our pharmacists will consult with your telehealth provider to provide comprehensive medication reviews. And we can even help with, this one usually perks everyone's ears up in the room when we're in person, prior authorization assistance. If we have access to history of therapies, our pharmacists can complete those prior authorizations for you from soup to nuts. We can also access more than medications at our sites. Our pharmacists, when allowed, will provide immunizations at the pharmacy. We expect immunizations to be one of the benefits coming out of COVID-19, that there'll be a surge in flu vaccinations. We also pill package. So how do we keep adherence? One of the great ways we do that is with our pill packaging. So the pharmacist will make sure that all of the medications are packaged appropriately for when the consumer needs them. It gives them an extra check to make sure that they take their medication on time, and it works very well. And of course, on-site pharmacy solves transportation issues. Many consumers rely on government-funded rides to come to their doctor's appointment, but they often are not getting a ride after their appointment to the pharmacy. They can see the prescriber when they're on site and get the prescription before they leave. Samar, do you want to talk about how we can integrate better with telehealth?
Yeah, so, it's really important to recognize that.
I think we can hear you, Samar.
Hold on. Can you hear me? Let's see. Can you hear me now? Rachel is saying she can hear me. Okay, so might be something on Kevin's side. Very good. You bring up a good point, Kevin, which is in a world where we're remote, how do we think about the relationship between the pharmacist and the prescriber, the physician or the nurse practitioner? Our viewpoint has been for a while that there needs to be a very close communicative relationship between these two stakeholders. The provider may be at a position where they're able to understand the overall arc of patient care and what medications are appropriate at a certain time. But the pharmacist is often in the trenches understanding how a patient is performing against his or her specified medication routine. Are they getting refills on time, et cetera? To create a linkage between the insights the pharmacists have and the insights the prescriber has are very important to creating well-rounded patient care. The fact that now everybody is working in a telehealth environment enables us to create these care teams that can coordinate a little bit better. So what we've done that we consider a best practice is we've established care team huddles. Care team huddles incorporate the psychiatrist or nurse practitioner, the pharmacist, case management staff, in order to have a patient-centered conversation around their adherence to a medication routine. This is something uniquely feasible now in a telehealth-first environment where everybody can coordinate and share information. This can, of course, be done also in an in-person environment and ought to be done as a best practice should a clinic have those resources. But making sure all the facets of information that involve patient care are discussed in one setting can often ensure fewer gaps in care manifest, and patients are responded to quickly and appropriately when we see gaps in care emerging. So, re-emphasizing the notion of huddles being a real driver of outcomes is central here. Kevin, I think, let's see, is your audio doing all right?
I can hear you through my computer. Can you hear me again?
Okay, so let's go to the next slide and back to you, Kevin.
Okay, great. So we've already talked about what integrated pharmacy can do for your consumers, but what can it do for your clinic? It really gives you a competitive advantage, and let's talk about that. So now you have another advantage to offer, benefit to offer your consumers, right? Dedicated pharmacy services, a dedicated pharmacy team that bring pharmacy to your consumers in a safe and supportive way. We've already talked about how we know that integrated pharmacy provides better medication adherence. So that means reduced emergency room and hospital visit stays, you achieve better clinical quality, and you position yourself with payers as we say move to a value-based world, but we are already in a value-based world. Payers are looking at medication adherence data whether you realize it or not. So you want to make sure that you have a team that is dedicated to the same goals and outcomes as your organization, and make sure that you have the visibility as an organization to monitor that medication adherence yourself. So along with reduced hospital and emergency room visit stays in COVID-19, they're going to reduce your consumers' potential COVID exposure. We know that that is where the highest concentration of COVID positive patients are, at hospitals and emergency rooms. So keeping them out of that is increasingly important, as our population, as you know, often deal with comorbid conditions which lead them at the worst outcomes for coronavirus. And it really closes the gap after the prescription is written. And I talked about this before. So it gives you more information about the prescribing. You write it, you have it, you choose the right therapy for a consumer. What happens to it next? Are they filling it? Are they staying on it? Are they not able to pay for it because the copay is too high? These are conversations that you deserve to know about and be able to make clinical judgments on with your consumers. Your patients deserve top of the line pharmacy care, and you deserve to have the most information about the therapies that you're prescribing to make sure that you can stay on the course of getting people to the outcomes where they need to be. Go to the next.
So as we continue through this, I want to take a moment and pause and ask the audience here a question around your adoption of telehealth and understand what services you've been able to bring into a virtual environment. So if you can take a moment here and select the multiple services on this survey here that you've now virtualized given the onset of COVID. This is multi-select, so there's not just one right answer. In fact, there is no right answer, but just curious how the attendees here have incorporated telehealth into their service lines and into their practices for the past couple months. So we'll wait just a minute or two, and then we'll review the results. Okay, the results are in, and similar to the survey that Genoa administered about a month ago, what we see is telepsychiatry is a predominant modality through virtualization. 83% of those who replied have brought in psychiatry to a virtual setting. But what I'm happy to see here is, and maybe this is a function of time, maybe it's a function of the attendees, is greater uptake of primary care and case management services in a virtual environment as well. Really thinking in a holistic way around patients and all their needs and trying to virtualize as many as possible. So really great to see that about half those who responded have brought their primary care services and case management services virtual as well to create good continuity for patients as they access care. So let's hop over to slide 16. Because that data helps us unpack, well, What changed? Why did this happen so quickly? Certainly the desire to create a strong, continuous experience for our patients and make sure that they are adherent and constantly in touch with their care team is central. And that's the driving thesis no matter what. It has always been. However, given the onset of COVID, what we've been able to observe is a regulatory environment that almost overnight transformed to favor the deployment of telehealth that was perhaps inhibiting our ability to do so previously. We saw 4 major regulatory changes enacted in basically a 48-hour period in March. We saw the exception granted under the Ryan-Haight Act, allowing for providers to deliver care via telemedicine and prescribe controlled substances to patients who they're seeing for the first time in a virtual setting. We saw the requirement for a provider to be licensed in the state where a patient is residing to be lifted by CMS at a federal level, allowing the possibility for providers to treat patients across state lines, really creating more liquidity in the marketplace and more access to care. We also saw the relaxation of enforcement of HIPAA requirements on the technology being used, so that clinics could use more consumer-oriented technologies for the adaptation of telehealth, things like FaceTime or Skype, tools that are perhaps easier to use than traditional HIPAA-compliant softwares or hardwares. And then lastly, we saw reimbursement expand. We saw over 100 new services become eligible for telehealth reimbursement that weren't reimbursed via telehealth prior to the onset of COVID. And we also saw the geographic boundaries of where a patient needed to be expand as well. Typically, a patient being served in their home was not a reimbursable care setting, with few exceptions. CMS changed that regulation at least temporarily a couple months ago, and now enables us, most importantly, to see patients in their home and bring care to where they are, meet patients where they are. Big questions abound around whether these regulations will stick. But every day we get new guidance from CMS. Seema Verma is out there talking every day about how these regulations and rollbacks have been meaningfully beneficial to patient care. So we are hopeful that these regulations are enshrined in the statute and made permanent, but it's wise to recognize that some of this may get rolled back, and we may have to consider some sort of nuanced middle ground. For example, an environment where telephonic sessions are not reimbursed at the same rate as video sessions. These are things that we're going to have to grapple with as CMS provides guidance. The one thing they did make clear, and this was only a couple of days ago, is that they anticipate a glide path, that where regulations are going to be reinstated, it won't be overnight and create a dramatic shift in what their requirements are, but rather that they plan to institute transitionary pathways back to the regulatory norms. So I'm hopeful that any change here is navigable in a reasonable way. Let's go to the next slide, and I think hand it back to you, Kevin.
I think this is our next poll, Sama, right? So we're going to take a quick poll to address what the future of integrated telehealth and pharmacy looks like. Let's launch the next poll. So what keeps you up at night about the future of telehealth? This one, you can choose one option. Is it the ability to build relationships, keeping consumers on their medications, regulatory changes or requirements, or attracting new consumers? So we'll give everyone a moment there to select their options. Or their option. All right, Summer, it's exactly what you just talked about. Regulatory changes and requirements is the kind of main key point here, and the ability to build relationships.
Yeah, it's fascinating to see, and we can certainly talk about that more in the Q&A. So to leave time for the Q&A, I think this is where we wrap up, and we look forward to what the world looks like on the other side of this. We believe that over the past few months, we've observed certainly some challenges in healthcare administration and delivery for the behavioral health population, but quite candidly, we've also observed some new best practices emerge. And our hope is that the forward future is the best case scenario of taking all the best practices we have identified around integrating care, creating better communication between providers, meeting patients where they are, creating more consistency, seeing patients reduce their no-show rates, finding ways for pharmacists to engage patients in an asynchronous or virtual manner. All of these best practices persist in a future that is a bit more integrated and a bit more oriented towards convenience and access for patients. We see the potential to provide telehealth not just as a medium, but as a modality, as a real tool to improve patient care, and are hopeful that those in the audience embrace this future and help us serve our patients better collectively together. We need that support now more than ever as we see growth in behavioral health conditions and better destigmatization of behavioral health broadly as well. So I think that is it for our formal slides, and we'll turn it over to the moderators for a Q&A session now.
Great, thank you, gentlemen. That was a very informative presentation. So as Samer said, it's now time for a Q&A. If you have a question, you can use—
I apologize, my audio has gone out here once again. So any questions that come in, if someone wouldn't mind, one of the organizers putting that in the chat, and I'll happily take that.
Okay, we can handle that. So anyway, as an attendee, you can use the question box on the GoToWebinar panel. The first one that's come in from just now, how does social distancing with physician-related administered medications work best with patients since COVID-19?
Yeah, that's a really hard one. And we saw that in the survey data. The lowest response for services delivered via telehealth was medication-assisted treatment. Now, not every state is a physician required to administer, MAT medications, but in many states they are, and that's where we're seeing challenges. Is how do you create continuous care when providers and patients aren't necessarily seeing themselves in person? What we are seeing anecdotally and from an observation perspective is that these types of treatments are considered essential healthcare services, and that exemptions have been granted to these organizations providing MAT services in order to allow for a provider to see a patient in person. What we're typically seeing is a reduction in number of patients that can be in a waiting room at a given time, smaller group settings, if group settings are happening at all, and the requirement that both patients and providers are wearing PPE and are fever tested or temperature tested before the administration of in-person medication, as may be required by law. So unfortunately, we don't have a great answer here. It's similar to hip replacements, right? Everybody who's been needing a hip replacement has kind of paused that for the past couple of months, hopeful that they can come out the other side and undergo that procedure. With MAT services, we don't have the luxury to wait. You don't want another onset or remission to create a degradation in patient condition. So certainly a challenging situation, no doubt.
Great. Thank you, Samer. The next question we have is, will telehealth regulations revert back to normal after COVID is behind us, whenever that may be?
Trying to speak to this as best we can. If you wouldn't mind going back a couple slides to the regulatory one here, I can kind of speak to it kind of item by item. I believe it was slide 16. Yeah. What we anticipate is, and don't hold us accountable for this, we anticipate the reimbursement relaxation and the Ryan Haight waiver to stay in some format. Indications from CMS indicate that those are the ones they're most focused on. I would find it hard to believe that FaceTime will be an applicable HIPAA acceptable tool to use for telehealth on the other side of this, but CMS has been very willing to say they want to look at the data and understand, what they need to keep for the benefit of patient care. So if the data shows that a tool like FaceTime is really driving better engagement between providers and patients, maybe that could be retained. I'm certainly not counting on it personally. Lastly, the piece that may be hardest to move is the state licensure waivers. This is not something that's adjudicated at a federal level alone. It requires participation from all 50 states' medical boards and licensure authorities. This would require a massive coordination of effort and regulatory repeal or relaxation. This is just tactically a harder thing to pull off, and I certainly wouldn't expect that it persists on the other side of COVID, though it could very well be the case that there's enough groundswell momentum that that agencies and state boards start to work in a coordinated way better on the other side of this, and perhaps make interstate licensure a bit easier or a bit more fluid.
Great, thank you. We're getting the questions kind of rolling through. Let's go to the one about, have you seen any medication shortages during COVID?
I can take that one. Can everyone hear me okay? I'm having difficulties with my audio. Samer, give me a nod? Yes, okay, thank you, sorry. We definitely have. We've seen medication shortages in the short term, and we expect even more medication shortages in the long term. Many prescription items have some sort of manufacturing in China or India. We have taken steps to ensure that we look at which medications we believe might be impacted for a long term to ensure that we have an adequate supply on hand. And we are working with other sources to make sure that we're able to source those from different manufacturers if the need arises. The important thing to note that, with an integrated pharmacy, that's really your first line to know if a medication is in short order. The pharmacist can give you a weekly update as to what they are expecting to be shortage or what unfortunately is already unavailable. And then you can work with the pharmacist to choose therapeutic alternatives that might be an option for the consumer while we're dealing with the shortage. Also a great way to, if medication is currently prescribed that requires laboratory monitoring and laboratory services aren't available, it gives the prescriber the way to interact with the pharmacist to determine another therapy that might not need such lab monitoring. Good question.
Great, thanks, Kevin. The next one we have, if the center is delivering meds, how are you collecting payments from patients that don't have credit cards or other forms of payment? Is it cash only?
So we do struggle with that, especially with the population that we serve. We make every effort to collect copays in a timely manner. While we still will accept cash, we have all of our delivery drivers using gloves to ensure every consumer interaction they have, they change the gloves, and any cash that they accept gets put into a receptacle that obviously comes back to the pharmacy and is processed. We have a strict rule of changing gloves between any consumer interaction. So we still will accept cash if that's the only way a consumer will pay. But we're also able to certainly, defer those copays to a later time when it's easier for the consumer to pay if they're not able to pay through mail or through the internet with a credit card or check.
Excellent, thank you. So let's see, my state Medicaid plans to discontinue payment for audio-only telehealth services on July 1st. Do you have any helpful hints on how to convert current audio-only clients to a video platform?
Yeah, it's a question we've heard from lots of our partners, and truthfully, the challenge is very real. A lot of clinics we've seen really lean into the telephonic modality of telehealth, given that CMS allowed for this. We've offered two forms of guidance. The first is it's going to require a little bit of extra outreach, reaching out to the patient and working with them off hours to understand what they need to be able to access services via video? Will they be able to use a smartphone? Do they have resources near and easily accessible to them to enable video services? Or are they truly only able to do telephonic, either because they don't have the hardware or they maybe don't have the financial resources to afford a data plan that allows for them to do the video services? The second piece of advice we've been giving is be methodical in collecting data around this and use that data to appeal to the state. So if you find that for your high needs members, only 50% of them can reasonably be expected to move to a video modality, then taking that data to the state and showcasing that half of your patients are not going to be able to continue care while maintaining social distancing if we are moving to a non-reimbursable telephonic environment, and see if that can move the needle in any capacity. Unfortunately, I don't have a great answer here, but the reality of the person who asked this question is the reality of many clinics we're working with today.
Thank you, Samer. We have kind of a two-part question. What is your delivery charge, and are most of your pharmacists BCPP?
I'm sorry, the second part cut off. Are most of our pharmacists?
It says BCPP.
BCPP. I'd have to look up what that acronym means, to be perfectly honest. But the first part is very easy. The first part is very easy. We don't charge for delivery. We don't charge for delivery or mailing. We understand it's the right thing to do for consumers who have transportation issues. So we never push those fees onto the clinic nor the consumers. I'll do a quick Google search of BCPP and
it's board certified pharmacological specialists.
So not all of our pharmacists have that.
Hold on, somebody dropped in as one behind it.
Board certified psychiatric pharmacist. Thank you, Emily.
Yes.
Yep. No, not all of our pharmacists are. However, we do offer enhanced psychiatric training to all of our pharmacists, and we encourage them all to do so. Pharmacists receive pretty rigorous psychiatric care when they're in pharmacy school. I mean, I certainly remember it, even though it's been almost 2 decades now. But it certainly there's a room for improvement. So we partner with a college to offer a psychiatric college course that really gives our pharmacists a competitive edge to understand more in depth the psychiatric conditions that they may be treating with their consumers.
Okay. I have kind of a complicated question here. I'm going to see if I can make sense of it, and it might fall outside the guideline or the boundaries of what we kind of talked about here, but I'll see what I can do. So I'm going to start with the last part of the question where the attendee said that this question is going to really apply more to complex healthcare issues like cardio, oncology, and lifestyle diseases. And the question is, how do we enhance the outcome quality? Sorry, somebody keeps shifting this panel. Quality and efficacy of healthcare via telehealth, telemedicine, and remote patient management. So what can we do to improve that kind of, I guess, any kind of telemedicine or virtual medicine or remote management for more complicated conditions? I don't know if that kind of falls in the purview of this or not.
I'm happy to speak to that. It's a very thoughtful question. Mm-hmm. If we look at the data that's been published, and there's been, peer-reviewed data coming out about the efficacy of telehealth for the past decade, that data says pretty unequivocally that telehealth is as good of a modality of delivering care as in-person services, both on a diagnosis basis and an outcomes basis. Now, telehealth here has been defined as two-way synchronous video, and that seems to work both for complex patients and non-complex patients. What hasn't been studied as much is, can remote patient monitoring, can tools that patients are incorporating, patient-reported outcomes, et cetera, be used to create a more well-rounded and improved patient experience and series of outcomes? It's early days here, and there was no window to really look at this in detail because we didn't have a mass migration to telehealth to understand what's the next generation of telehealth delivery to look like. All of that behind us, I would suggest that at the very least, we're talking about care at parity, and via telehealth, we certainly have the room to improve. When you look at things like decreased no-show rates, when you look at things like improved patient satisfaction with the telehealth experience, that to me is an indicator that underneath that is data that can be studied, information that can be published on how we create better outcomes for patients while incorporating additional tools on top of synchronous video, tools like asynchronous check-ins, remote patient monitoring, et cetera. So the world is still in front of us to discover there, but it's certainly promising at this stage.
Great, thank you. I wasn't sure how easy that was going to be to answer. So thank you, that was a good response. The last question I see is, do you fear if you deliver via mail that the patient may claim they did not get it? So I guess how are you confirming delivery and receipt by patients of medications?
Yeah, believe it or not, the U.S. Postal Service has very advanced tracking, probably more than the layperson realizes. They actually track packages, and we send all of our packaging out with tracking. They can go down to GPS coordinates within like 10 feet of where the package was left. So while there certainly are some instances where consumers will claim that they don't get a medication, usually it's just that it's delayed with the Postal Service. We've had very few instances across the company where a package has been lost or was undeliverable to the consumer. It's easier than ever for people to get their mail because, let's face it, almost everyone's at home now. It has not been as much of an issue as we even anticipated it might be. It was actually a concern of ours, so that's a very apropos question.
Great. Again, lots of questions today. So here's the next one. Has the data that you've been referencing in the deck been collected by Genoa, or can you share the sources of the data sets for their review?
Depends which data we're speaking to. I believe a lot of what Kevin and I were speaking to reference some of our published studies, so those are certainly shareable. There are some specific Optum level insights that we shared here as well, which would be more internal and proprietary and not shareable, but we can certainly point folks to our studies. In fact, it's quite easy. If you go to genoahealthcare.com, we've got all our published studies listed on our website, but we can work with Open Minds to figure out how to share more detailed information after this.
Thank you, Sam. Kevin, there's a follow-up to the one about the mailing
Sure.
confidence, and it was the fear is that she says we use a lot of benzodiazepines. So does that, I don't know, that changes the dynamic or not?
Yeah. So controlled substances, when we do send those out via the mail, we require signature and confirmation of recipient. Of course, signature has been waived by just about every major delivery carrier. So the carrier will actually just ask the person's name or ask to see an ID and verify it off of that and mark it that has been obtained by that actual consumer. We make sure to include that on all controlled substances that are mailed out.
The last question I see, do you use any self-review checklists or symptom reporting checklists for assisting remote telepharmacy or MAT services?
Could you repeat that?
Do you use any self-review checklists or symptom reporting checklists for assisting remote telepharmacy or MAT services? So I'm guessing the patient or the recipient kind of providing a verification of symptomology, it sounds like, if I'm getting that right.
For our consumers, since so very few of them are coming into the clinics where we're located, many of our clinic partners have begun integrating symptom checking as well as temperature checking at their locations, if this is what you're referring to. We do this routinely in our pharmacies with all of our employees to ensure safety and reduce transmission. I'm not sure what the regards to MAT the question would refer to, but we are taking every precaution absolutely that we can at the pharmacy to make sure that consumers and patients stay safe and and reduce the risk of transmission.
Excellent. Another question just popped in. Do you use measurement-based care?
Measurement-based care? Good, sir.
I can speak to it on the our telehealth platform does incorporate measurement-based care. We have a partnership with a vendor that administers PHQ-9, GAD-7, audit, and the ability to administer many other clinically validated screens and scales. We find that to be elemental to the next generation of behavioral health delivery. So certainly we're at the early chapters, and we've only begun rolling out our measurement-based care work, but we envision it as a foundational future to the services we're delivering.
Okay. The follow-up question about the self-review checklist in telepharmacy and MAT services refers to the effectiveness of the meds for treatment impact purposes.
Ultimately, the prescriber is the one who chooses the medications to be prescribed, but our pharmacists routinely perform medication therapy management, in which we do comprehensive medication review of a consumer's medications to their ICD-10 codes to make sure that they are optimized for outcomes and to reduce interactions. We don't have any particular measure that any pharmacists work by, but another thing that we also work for is adherence to medications, which we've spoken to numerous times here. We really track antipsychotics, antidepressants, and mood stabilizers, particularly because we know that the adherence to those medications can have the largest impact on outcomes, reducing ER visits and hospitalization stays.
Thank you. The last question, it looks like, are pharmacists allowed to sign consent forms in treatment plans, or do they need psychiatrists to co-sign?
Yes. Go ahead, Samar. I see you wanted to chime in there.
No,
okay. Pharmacists cannot sign treatment plans as of yet. We would love to see the scope of pharmacists to be changed to provider status. Anyone who's willing to speak to that, to their local legislation, and we'd certainly appreciate that. Pharmacists deserve to be recognized as providers of care as well. And should that move forward in the future, we would be able to have such collaborative practice to be able to do what was exactly stated in the question.
Excellent. All right, we are coming to the top of the hour, and that looks like we have run the course with our questions. Thank you. That was a very engaging discussion and Q&A session. So thank you, Samir and Kevin, and thank you all for joining us for the Integrated Pharmacy and Telehealth Deliver Complete Care session brought to you by Genoa and Open Minds. As a reminder, all participants will receive an email in the next few days containing a link that will allow you to download a PDF copy of the presentation and also access a recording, an audio recording of the file. So thank you all and have a wonderful day.
Thank you. Stay safe.